All right, today we're going to tackle Alzheimer's disease. We're going to go on a journey starting with what you see in the clinic and tracing it all the way down to the chaos happening inside a single neuron. Let's dive in.
Okay, so let's set the stage with a classic case you'll definitely see. You have a 75-year-old patient, and they're telling you they're becoming more forgetful, maybe having trouble with their finances. The big question is, what's actually happening inside their brain on a molecular level?
So, before we can even begin to understand what goes wrong in Alzheimer's, we have to know what right looks like, right? We need to look at how a healthy neuron keeps things running smoothly. Think of it as its daily housekeeping. So, let's meet our first key player, amyloid precursor protein, or APP for short. Now, this protein lives in the cell membrane, and its day job is probably helping neurons grow and repair themselves. And just like pretty much everything in our body, APP has a life cycle. It does its job, and then it needs to be broken down and recycled. Totally normal.
And next up, we've got our second major player, the tau protein. Now, if you want a great way to remember what tau does, just picture microtubules as these tiny railway tracks inside the neuron. They're super important for shipping nutrients and other molecules around. Well, tau proteins are like the railroad ties. They bind to the tracks and keep them stable, making sure the whole transport system doesn't just fall apart.
Okay, so how does the body normally clean up and recycle that AAP protein we just talked about? Well, it's a pretty clean two-step process. First, an enzyme called alpha secretase comes in and makes a cut. Then another enzyme, gamma secretase, makes the second cut. What you're left with is this small, soluble piece that's totally harmless. It just dissolves and gets cleared away. No fuss, no mess. This is the healthy way. We call it the non-amyloidogenic pathway. Everything's tidy.
So, where does Alzheimer's come into the picture? Well, it all starts when this neat and tidy housekeeping system completely fails. It's really a story of two things going wrong. You get these plaques that form outside the neuron and tangles that form inside.
And you've got to keep this distinction straight. It's absolutely crucial for your exams. The amyloid plaques, they're made of a protein called beta-amyloid, and they build up in the space between neurons, so extracellularly. The neurofibrillary tangles, those are made of that tau protein we talked about, but a messed up version of it. And they form inside the neuron itself, intracellularly. Outside versus inside. That's a key point.
So let's break down how these nasty plaques get made. In Alzheimer's, the process goes down a different path. Instead of alpha secretase making that first cut, a different enzyme, beta secretase, shows up to the party. Gamma secretase still makes the second cut, but because that first cut happened in a different spot, you end up with a totally different product. You get this insoluble, kind of sticky little piece called amyloid beta 42. And because it's so sticky, it starts clumping together with other sticky pieces, forming those big beta-amyloid plaques outside the neuron.
And what happens when these plaques build up? Well, it causes a couple of big problems. First, as you can see right here in this histology slide, these plaques are dense clumps of gunk that physically get in the way. They jam up the synapse, which makes it really hard for neurons to talk to each other. And second, they tick off the immune system in the brain, triggering inflammation that causes even more damage to the surrounding healthy cells.
But wait, the story's not over. The mess outside the cell, well, it actually starts to cause trouble inside the cell. We think that this buildup of beta-amyloid plaques is the trigger for the second half of the pathology. It's like it sends a danger signal that activates a bunch of enzymes inside the neuron called kinases.
So once these kinases get activated, they just go haywire. They find our good old tau proteins, the railway ties, and they start sticking way too many phosphate groups onto them. This is called hyperphosphorylation. This completely changes tau's shape, and it can't hold on to the microtubule tracks anymore, so it lets go. And what happens when you pull out all the ties from a railway track? The whole thing falls apart. The cell's transport system just grinds to a halt, and the neuron literally starts to starve. To make things even worse, all those now useless, hyperphosphorylated tau proteins clump together inside the cell, forming the neurofibrillary tangles. You can see them right here in the image, these dark, kind of flame-shaped tangles that are just choking the inside of the neuron. So now you have a cell with a broken transport system, and it's stuffed full of this tangled-up protein. At this point, the neuron just can't function anymore. It gives up and triggers apoptosis, programmed cell death. And it's this massive death of neurons that causes the brain to shrink and leads to the cognitive decline we see in patients.
Okay, so we've gone deep into the molecular weeds. Now let's zoom back out.
How does all this cell death and molecular chaos actually translate into the signs and symptoms we see in our patient in the clinic?
The progression of Alzheimer's is unfortunately pretty predictable. It usually kicks off in the medial temporal lobe, specifically hitting the hippocampus, which is, our memory center. That's why the very first symptom is almost always short-term memory loss. We often call this stage mild cognitive impairment, or MCI. But as more neurons die and the disease spreads, it starts to affect other parts of the brain. That's when you see problems with language or with doing simple learned tasks. Eventually, in the late stages, the damage is just so widespread that patients start to lose their long-term memories too, and they become completely dependent on others for their care.
Now, technically, the only way to be 100% sure someone has Alzheimer's is to look at their brain on autopsy. But obviously, we need tools to make a diagnosis while the patient is still with us, and we have some pretty good ones. If you get an MRI or CT, you'll often see the brain has shrunk, what we call atrophy, especially in that hippocampus region. We can even do special PET scans that can actually light up and show us the amyloid plaques. And finally, we can do a spinal tap to check the cerebral spinal fluid. This is super high yield. In Alzheimer's, the A-beta-42 levels will be low. Why? Because it's all trapped in the brain, stuck in those plaques, so it's not floating around in the CSF. And the phosphorylated tau levels will be high, because it's spilling out of all those dying neurons. All right, so let's shift gears a bit and talk about the clinical approach. What are the big risk factors we need to know about, and how do we actually manage this disease today? Genetics are a really big piece of the puzzle here. For the most common type, the late onset or sporadic form, the single biggest genetic risk factor is having the APOE4 allele. See, the APOE protein is supposed to help clear beta-amyloid out of the brain, but this E4 version just doesn't do a very good job. Then you have the rare early-onset familial types, which are caused by direct mutations in genes like APP itself. And finally, it's really important to remember the connection with Down syndrome. People with trisomy 21 have a whole extra copy of chromosome 21, and that's where the APP gene lives. So they're basically overproducing amyloid beta their entire lives. This is a really crucial point to drive home with patients and families. Right now, our treatments only manage the symptoms. They do not stop or reverse the disease itself. We have medications like cholinesterase inhibitors that can give a temporary boost to cognition, but honestly, a huge part of managing Alzheimer's is non-pharmacologic. It's about supporting the caregivers, making sure the patient is safe, things like stopping driving or making the home safer, and managing the really difficult behavioral symptoms that often come up. Okay, let's wrap this up with a high-yield recap. These are the things you absolutely have to know. Number 1. Alzheimer's is defined by two things: extracellular A-beta plaques and intracellular tau tangles. Got it? Number 2, clinically, it starts with short-term memory loss because the medial temporal lobe gets hit first. Number 3, the APOE4 allele is your biggest genetic risk factor for the common late-onset form. Number 4, you can support the diagnosis with an MRI showing atrophy and that classic CSF profile: low A-beta-42, high p-tau. And last but not least, remember, our current treatments are symptomatic only. There is no cure yet. So if you're going to remember one thing from all of this, let it be this: Alzheimer's disease is, at its core, a story of two misfolded proteins. You've got amyloid beta causing trouble outside the neuron and tau causing chaos inside. And together, these two proteins systematically dismantle the brain's entire communication network.